Hi, everyone, and welcome to our event, Flipping the Script, a teach-in on homelessness and diabetes management. This event is co-sponsored by the NYU School of Medicine's Health by Housing Lab and the Health and Housing Consortium. My name is Constance Woodson. I served as the 2023 Health by Housing Lab Summer Consultant with lived experience of homelessness. We are so excited that you're here. This topic is important to me because I've seen firsthand how difficult it is for shelter residents to manage their diabetes. Today, we will hear from 3 speakers sharing how homelessness impacted the way they were able to control their health. Next slide, please. Some housekeeping rules are, because this is a webinar, everyone is on mute with videos off. The chat box is disabled. To enable or disable subtitles, select live transcript at the bottom of the screen. Please use the Q&A box, not the chat box, to submit questions for panelists, upvote other attendee questions, and make comments. We will answer as many questions as we can during the Q&A portion. Recording will be made available at a later date. And share your thoughts on X or Twitter using hashtag flipping the script. Next slide, please. The event will be moderated by Dr. Michael Shen. He is the clinical director of the Woodhull Safety Net Clinic, a clinic and street van that serves New Yorkers experiencing homelessness. He is also a MPA candidate at NYU Wagner School of Public Service, studying health policy analysis. I will now turn it over to Michael to introduce today's speakers.
Thanks so much, Constance. Hi, everyone. I'm Michael. So as Constance mentioned, I'm a primary care doctor at Woodhull, serving our neighbors experiencing homelessness in our community here in Bed-Stuy and Bushwick. I want to start by setting the stage in New York City and for this conversation. So as we all know, we are experiencing a homelessness crisis here. We have over 100,000 people who are living in DHS shelters, and that represents about 1% of New York on any one given night, which is a lot. And those who live in shelter, they are a very diverse population, including single adults, families with children, many of whom have lived a while here in New York, some of whom have recently arrived. And you can imagine that they also represent a diverse breadth of shelter experiences. And when it comes to health and experiencing homelessness, and specifically diabetes, those with diabetes were up to 48 times more likely to become homeless during the pandemic, according to the American Diabetes Association. And in the hospital system where I work, New York City Health and Hospitals, public hospital system, we serve about 5 or 6% of our population is experiencing homelessness. And over half of those people are people with chronic diseases. And of those people, 21% have diabetes. So, I think that this conversation is very relevant today. So I'm honored to have Mr. Neville Joseph, Mr. Barry Joyner, and Mr. David Gaynor joining us today as our panelists. Today's event is about learning from you 3. So all of the healthcare professionals and other professionals on this call, including myself, we're going to be listening and we're going to be learning. So I'm going to let each of you introduce yourselves. Would you each share a little bit about your experience of being homeless or living in supportive housing as somebody with diabetes? We're going to start with Mr. Neville Joseph. I'm going to have you unmute. Thank you.
Good afternoon, everybody. My name is Neville Joseph. I've had diabetes since 1996. Didn't know, I probably had before, but didn't know. I found out once I I was homeless and I was in the shelter, that I had diabetes, type 2 diabetes. And the shelter system that I was in at Ward's Island was difficult, very, very difficult, to the point that people be getting stabbed and beat and stuff like that. And at one point I left the shelter and was on the street. Back in those days, as compared to now, our insulins were in needle forms, and we didn't have the pens like we have now. And being on the street with needles, and it was very, very difficult for me to take my insulin. First of all, it needed to be refrigerated, and I just didn't want to take needles on the street. People think that I was, taking drugs. And so it was a very difficult time for me. Now that we have the pens, it's a lot more easier to administer the insulin. But mentally, it was very hard. Just the mere fact of being homeless and then having to be facilitated with diabetes, and then the complications came with that. I didn't even realize what was going on, because my fingers and my toes began to get numb. And I thought it was because of the slippers that I was wearing. And it just worsened until I went to the doctor, and he said that I have neuropathy in my fingers and toes. And they put me on medication, which never worked. Still to today, my toes and my fingers are very numb. It's hard to pick up silver and count money and stuff like that, and even write sometimes. Currently now I living at a SRO, ICL, and it's a big difference now because my medication comes through mail from pharmacy, and I have my own studio apartment, and I'm able to take my medicine, as prescribed. And in addition, I changed my diet because in the shelter, you have to eat what they give you. So now I have a choice in eating healthy, which I take advantage of. Exercises, I need to do more of that. I haven't been doing too much exercise, but that does play a toll with your diabetes. Being in ICL gave me the opportunity to even work. ICL hired me in the beginning as one of the maintenance people, and then I got promoted to a counselor, which helped me so much. I was counseling people on domestic violence and family matters, and by me counseling the people, all my clients, I was really helping myself, because the problems that I was having were so similar, and I was able to give them advice. And the answers that I had was answers that I needed for myself, was in myself, and I just didn't know it until I was helping somebody else. So me counseling people became very, very therapeutic for me, and I loved it until I retired 2 years ago.
Thanks so much, Neville. I'm going to have the same question for Mr. Barry Joyner. Could you share a little bit about your experience of homelessness and or living in supportive housing as somebody with diabetes?
Yes, I will. Good afternoon, everyone. My name is Barry Joyner. I'm a senior citizen at the age of 68. I reside at this time in supported housing, which is breaking ground that dominates. My journey began about 20 years ago. I was on drugs and homeless at the same time. I was homeless due to being on drugs. Okay, as a vet, I tried to get housing, but it was denied to me because I wasn't clean. I was told to get 6 months clean. Each time I tried to do that, I would relapse. So I got frustrated. I told them they couldn't help me. I went to NA, Narcotic Anonymous, and they did a lot of advocating for me with Human Resource Administration, and they got me supportive housing. Okay, that was like one of the best things that could happen to me. And it also helped me get off drugs, because when I got into supportive housing, I was able to join an adult day healthcare center. Okay, in that center, I was able to deal with my drug problem. I was able to learn about chronic illness. I learned while I was in there that I had diabetes. Okay, I was a peer counselor there. I also founded Narcotics Anonymous. I founded in chair for 7 years. Okay, while I was there, I helped a lot of people. And before, at the end of leaving there, I started working on my KSAC. When I got out of there, I started working on my KSAC. Okay, my diabetes had led me through basically to dialysis, high blood pressure, dialysis. As you know, it's a chronic illness. Having housing helped me to be able to control my diet, be able to eat the right things, be able to store food, be able to rest the way I need to. It's very important that I'm able to take a shower every day just to refresh myself. You know, so housing has been a very big, important thing in my life. And I see housing as harm reduction, because after getting housing, I was able to deal with a whole lot of other issues, especially my diabetes, which is the most detrimental chronic illness I had. You know, like at this point in my life, I'm on dialysis. And I've been on it for 3 years, but I've been dealing with it pretty good. I'm an advocate at this time. I work with a place called Family Center, which is one of yours, Consortium. I'm on the Community Advisory Council. I'm an advocate for the homeless. I'm a general advocate in the community. One thing I do for my diabetes, and I've been doing for the past 7 years, was riding bike. I'm a cyclist. And at present, I work with the community garden in my neighborhood, and I work with the community in my building. So advocating is basically my lifestyle, you know. And I'm glad to be a part of this panel, because it gives me a chance to share my experience, strength, and hope. And that's it for me.
Amazing. Thank you for telling us about your story, Barry. And it's really great to hear about the advocacy work that you're doing.
Mhm.
I'm going to pass the mic on to Mr. David Gaynor. If you could introduce yourself and your background as well.
Oh, good morning, good afternoon. My name is David Gaynor, and I'm a homeless union leader with Vocal New York. We are directly impacted community members who joined the political fight to end HIV, AIDS, mass incarceration, and the war on drugs and homelessness. I myself, for 13 years, was homeless. And if it weren't for the city FEPS program, am I? Oh,
You're so good.
who said I hear myself? Oh, pardon me. No, I got it. I'm sorry for that. If it wasn't for the city FEPS, I would probably not be able to stand on my feet in front of you today. I'm a trained chef, skilled in preparing nutritious and healthy meals for others, but while in the shelter, I was unable to provide that for myself as a diabetic person. Despite being active and successful in my apartment search. As soon as I entered the shelter, I was repeatedly told there was no voucher ready for me yet. I played a waiting game for months and months that turned into a year. This was a year of eating child-sized portions of malnutritious food, I don't know, state food, rotten food. My health suffered and led to amputations of my extremities. And I don't think no one should have to suffer months without a nutritious meal that impact their health. And I'm lucky to have gotten out in time to save, I don't know, my entire legs. So we should engage in conversation and surrounding strengthening and boosting and infrastructure of care for the shelters and the homeless people that need this to be provided, because they're not basically not trained, or they're not telling the information that needs to be presented upon intake. They just want you to do 90 days and sit there and wait when you could be basically trying to better yourself, trying to move ahead. Thank you.
Thanks so much, David. I think all of your introductions, all of your experiences bring up a lot of the issues that I want to talk about during our Q&A right now. I kind of want to start with, several of you mentioned kind of how difficult it is in shelter to take care of your health. And I know that as a primary care doctor, diet and exercise are two of the main things that I encourage people to do, but those things are so difficult when you don't have stable housing. I was wondering if you could tell us, maybe we can start with the food, like you just mentioned, David. What is it like in shelter when it comes to diet and nutrition? And then relate that to how how that experience affects how you take care of your health.
But basically, it's more like everybody has to eat the same food, even if you have a special diet. Like some people, they might be lactose, or people that don't eat meat, or some people that might have religious reasons. They don't eat certain meats, but we were just given these, I don't know, they were like school lunches to me, stuff you give the kids. And we had to endure that basically like breakfast, lunch, and dinner. So it was more like whatever the money might have been provided for, they didn't provide it. It was like TV dinners. See, and the facility, which I don't mind telling, was Campbell House in Brooklyn. They had a kitchen the size of a cafeteria, and I offered many times to lend my expertise. If they was going to find me a job, they could have hired me there to be the nutritious person, But no, they didn't want to do that. They wanted to have food brought in and heated up in the kitchen. They was using the ovens that was upstairs to heat up the food for the clients. And I know for a simple fact that food must be maintained at a certain temperature, or you'll get a born, illness. See, so they'll heat it up in the oven, and then they'll bring it down and put it in the steam table, which was not turned on. So basically, that was just a serving. So a serving table, they put it, give you what you were supposed to have. It's like, a chow line, like in jail. I wouldn't know how that goes, but I mean, like in a prison camp. And you had one microwave to heat up your food. Now, can you imagine that with hundreds of people waiting to eat? And they were only giving you a certain amount of time to eat, from 5 o'clock to maybe 5:30, going on 6 o'clock. See, and then one time they were doing dorm to dorm, but I mean, to have nutritious meals is, atrocious. They should have just did like my plan, but they were, oh no, well, we can't do that. See, and they weren't, the people that were doing it were not even properly trained in food safety or food serve safe. They were the maintenance man giving us food or the secretary. See, so whoever was there that day, it wasn't a professional. So you don't know what, if they, half the time they weren't wearing gloves, they weren't wearing hair nets. So you could have got anything. I myself I refused to eat that. So I don't know, like I do know that you're supposed to sign for it. But if I didn't sign for it, I know my name was forged. Because if you are giving this facility money for food, and if you got 70 people, there should be 70 signatures for breakfast, lunch, and dinner, unless that individual is either sick or at work. I was neither or neither. So I basically can't understand how these people that are doing this are improperly trained, but they having these titles as far as like it's giving them some type of power, stigma. See, you're telling me you're a supervisor, but when I'm asking you, what about this place to rent or the doctor, you're telling me that's above your pay grade and you don't know what I'm talking about. So now I have to go find your supervisor. And if they don't know, then I have to find another supervisor, or I need to find out who's running this facility. Where's the donation come? I need to find out so I can let them know basically how they're being, the clients are being treated. And they're not getting the A1 quality service that you predict. You're telling me this is the Holiday Inn, but then I'm getting, like Granny and Jeffro and all this type of
And it sounds like the food was not only not nutritious, oftentimes it felt unsafe, and it also felt like it was out of your control. And you did mention, you didn't eat at shelter all the time. Neville, Barry, I wanted to hear if your experiences in shelter were similar, and if you also looked for nutrition elsewhere, how that was like. Was it possible,
Yes,
to find that kind of control?
It was very, I said it was very hard on the pockets. Most of the time after I found a job at NYU and New York, Brooklyn Botanical Garden, see, because they was trying to give me jobs at McDonald's, and I told them I have an associate degree in culinary arts. So I needed to make more money than what they were giving me. And they were inclined telling me, if you make more than that, you will lose certain benefits. And which I told them I was very happy with that, because that would let them know that I can take care of myself and I could provide for housing or pay my rent. See, they were trying to keep me there as far as a meal ticket. See, they weren't giving me what my capability. Like if there was a doctor there, they wouldn't get him a hospital job. They get him a clinic job to where all he do is draw blood and take bandages. But he's homeless. See, they didn't know that I had that, they just assumed, which was wrong. So I had to feed myself, basically either eating out or when I went to work to get the proper nutrition.
Neville, Barry, did you want to add to that?
Yes, I wanted to mention also, I agree with what he said about the food and the nutrition. I'm also a trained chef. That's one of the jobs that I did in my career. I'm 67 now, and I've worked as a paramedic, and I worked as a chef. I did many jobs. What I did do at the shelter, because it was just, if you wasn't into to fighting, and you had to find some way to keep yourself, stable. So what I did, I would volunteer in the kitchen, of course, because I figured I'd get some food like that. And I didn't let them know that I cooked. And after a while, I got the routines. I was just doing a lot of prep work, and one of the cooks never showed up, and we were stuck. And in the shelter system, it's like, well, if nobody shows up, y'all just go for broke. So I stepped in and I cooked the meal, and they hired me the next week. So I was part of the cooking crew. I cooked there for 2 years, and I was conscious of how I cleaned, prepared, and I try to give recommendations on baking thing, making things more nutritious for people that high blood pressure, and diabetes. And they pretty much, let me do that, do my thing when it came to that, I enjoyed that because a lot of times, if you haven't experienced homelessness yourself, and if you haven't experienced being in the shelter system, you wouldn't know. It's a devastating thing where someone controls your life. Everything in there is controlled, and you have to get used to things that you would never think that you had to get used to. For example, going to the bathroom with a row of toilets with 10 other guys going to the bathroom with you at the same time. I just couldn't get used to that. And in the morning, 9 o'clock, you got to leave. Can't come back until like 5 o'clock. So what do you do? Luckily, I would go to my father's house, and he was getting up in age. I would go over there and help him around the house, do his shop and stuff like that. That's how I would spend most of my days, caring for him, because he's also a diabetic. And he took insulin. Back then, I wasn't taking my insulin yet. I was on metformin, and then I got sick behind the metformin, and then put me back on insulin. But the whole idea of being in the shelter system, what people don't realize, once you leave the shelter systems, that mentality sometimes stays with you. And then I got to the point where I'm living in the SRO. I just don't like people telling me what to do. And sometimes they're telling me things that I need to do and I need to know. But it's just because I was spent so much time being told what to do. I just rebel sometimes, and it's something I need to work on. I really need to work on that, because I suffer a lot of times by not getting the help that I need, because I don't want anybody to tell me what to do,
So you mentioned, I wanted to ask about, you mentioned the lack of privacy, the bathroom situation. But also, before, you also mentioned, kind of the stigma around using needles, especially for insulin.
Yes.
And insulin is a mainstay. It is a mainstay of diabetes treatment, along with metformin and other pills. But even now, like with the pens, they still, they look like pens. They have needles in them, but a lot of people, depending on the insurance situation, might still be using vials and needles. Can you tell us a little bit about that experience of having to, inject insulin while living in shelter or living on the street, not having the kind of privacy to take care of your health?
Well, the problem that I had, I felt that, people looked at me like I was taking drugs, shooting, and some of the drug addicts would approach me for my needles, and it got to the point where, now it looks like I'm associated with all the drug dealers, the drug addicts, and it was difficult. It was really difficult. On the street, I just didn't take it at all. I just didn't take none of my insulin until I end up in the hospital, with my sugar sky high, I remember one time I went into the hospital, sugar was over 500, and I stayed in there for a while, and I had to think, because the guy in the bed next to me, he had his toes amputated, and I said, wow, I don't want that. And I was told that it could also affect my kidneys, and my mother, who was she went into renal failure and had to go on dialysis for 25 years until the dialysis stopped working. And they gave her 7 days and she died in 4 days, you know. So these are the things that I keep in mind, and I try to tell other people, you know, all you have is your health, you know, it's all you have. And you're gonna die regardless, but how do you want to die? You know, you want to suffer, you know, and how I live, it's gonna affect how my children live, you know. They see me taking my medicine, they know it's like a confirmation, this is what you do, you know. So it's helpful when I'm doing the right thing around them, you know.
Barry, I want to turn to you. I know that you had mentioned that you were diagnosed with diabetes after being in supportive housing. Is that, or after being housed? Is that correct?
Yes,
And-
that's correct. And my story is a little different when it comes to being in shelters. I never was in a shelter. However, I spent time in abandoned buildings. And when it came to eating and being on the street, my drug came first.
Mhm.
You know, my drugs always came first. When I ate, usually it was like something that wasn't nutritious, some chips or cakes, or you know, once in a while I would go to a school and they would give me a big bag of leftover food from the lunch, and I had to go to the abandoned building where I stayed and put it at the top of the closet. And in doing that, it might hold me for about a week, but it wasn't refrigerated, you know, and just being out there on the street, like I used drugs and I drank alcohol. So when I look at the things that I ate and all the alcohol that I drank, I know that had to contribute to me being diabetic. You know, I'm an ex-Marine. I felt like this. I ain't going in the shelter. Abandoned building is better. You know, I don't want nobody telling me what to do. You know, I got tired of paying taxes to smoking other people's house. So I had my own clubhouse, and that was where I stayed, unless I slept on the couch of somebody's floor. You know, but that's been my experience. And just being out on the street, you around people getting high, they would give you something to get high before they give you something to eat, because they getting high themselves. They're not trying to feed you. You know, you'd be lucky if you get something to say, oh, well, I'll pay you back, or you know what I mean? So it was like touch and go when it came to eating. And you know, sometimes you can be real hungry and wake up saying I'm gonna eat, but when you get that money, you go put it towards drug use. So like, you know, having housing for me was very harm reductive when it came to my chronic illness, when it came to me just trying to get off the drugs. You know, I would always put that straight out there, that having shelter helped save my life. It helped me get off drugs, and it helped me to have nutritious meal and store food and take care of myself.
Mhm. And, you know, I often think about the fact that substance use disorder and mental health and, you know, your physical health, they all come together in that way that you're describing. They don't just exist apart from each other. They're affecting each other all the time. I kind of wonder, during the periods of your lives where you were experiencing homelessness, where did the healthcare system come into play? What was your interaction with hospitals or with clinics or with doctors, or other healthcare professionals? What did that look like during that time of your life?
I'm gonna be honest with you. For me, when you're talking about health and the healthcare system, when I got incarcerated, that was like being rescued from the streets and going on a vacation. The doctor, you see the doctor, you can take all the tests, HIV, whatever, and they would take care of you as long as you're in there. And that was my experience with being homeless and dealing with them, because really, when I was homeless, I didn't address none of my health issues. You know, it was after I got a place to stay. That's why I said, you know, giving someone shelter is really harm reductive. You know, to a person surviving, you know, with any type of chronic illness or being on drugs, which is, I guess, another chronic illness. Yeah.
And I just want to jump in here and say that, like, I'm just going to call out the fact that our healthcare system has failed a lot of people, that we often serve to traumatize people more, especially those who experience homelessness. I want to recognize that and just give us all permission to talk about that. Not permission, because you don't need that to talk about it, but I want us to really address that and talk about that. And that's kind of why I'm wondering what your experiences were during that time, because I know that it's very difficult for a lot of people to interact with the healthcare system when they're going through something as difficult as homelessness. David, Neville, what are your thoughts there?
Well, my interaction with the healthcare system while I was in the shelter system was very positive. I was at Ward's Island, and then I volunteered in the kitchen, and I also volunteered with the outreach, where we would go to the airport. You wouldn't believe it. People live in the airports, and the reason why is because it's clean there. You know, it's and you can make money, you can hustle the baggage and stuff like that. And I would go work with the outreach 3 days a week. By me doing that, we would take people and bring them to the hospital. I got to know some of the people at Metropolitan Hospital, and then I got a doctor there, Dr. Eiskoff, for my mental health, and it was very positive, you know. Except I mean, I had a couple of incidents where I chose to tell how I was really feeling, and which caused them to not let me leave. You know, I stayed there for about a month and a half because I told them how I really felt. You know, as far as you know, being suicidal, and because of the fact that I tried it twice before, so they kept me. But other than that, you know, I got to know the people in Metropolitan Hospital well, you know, and they really treated me very nice there, you know. I don't know if it's because I was part of the outreach team or what, but it was a positive experience. As a matter of fact, that was the highlight of my day sometimes, going to the hospital, you know, and talking to some of the staff there, you know, while I was waiting to be seen, you know. It was very positive.
Can I add, basically, the healthcare system in the shelters needs to be changed because they have some type of stipulation. If you go to the hospital longer than 3 days, you lose your bed. And I couldn't understand it because I had surgery and they knew I was in the hospital to have surgery for amputation due to the fact that I didn't get the proper medical or direction to a clinic due to all the diseases that might have been in there because they didn't fully have a staff to sterilize or clean, because every day is somebody new coming in and they're not really, you know, basically like say, oh, well, this person got that, so we gotta quarantine them there. See, so when I went there, they was telling me a whole lot of malarkey. Oh yeah, don't worry about it. You better be here. See, and most of the people that were in there when they were sick, they were afraid to go to doctor because in fear of 3 days, if they still in the hospital and they didn't get well, they come back. You know, they'll come back within 2 days, but they didn't really get the proper care. See, they'll sign themselves out. And I couldn't understand that. And then, like he had said, mentioned before, most of your belongings that you either gathered up or you came there with or discarded because nobody knows where they're at. But they were in your room or in your locker. But once you're, time, like they were treating you like you were in a dog shelter, like after if nobody claims them, they got to destroy them. And these are human beings. See, they weren't helping. They were instigating more problems. See, because as soon as they get rid of you, they got another bed for somebody new. But now you back to homeless and you back on square one, like you didn't go past go, you didn't get that $200, you had went directly to jail. So that escalates your attitude to where you have to take it out on somebody because they lost your stuff. They lost maybe all your history, your birth certificate, all of these things that you need to function. Because the first thing people ask you when you try to get something is like, where's your ID? This and that. And you say, well, they lost it at the shelter. So now you have to go back and find this all out. But if you don't have the proper money or the channels or people, the agencies to help you, you're back in the street trying to survive. That rule needs to be changed.
That's such a common experience from the patients that I take care of as well. That there's that barrier of if you leave, you just never know what's going to happen with your stuff. You don't know what's going to happen with your bed. That itself is kind of a barrier to wanting to go seek care where you might be admitted. You might have to stay for a little while. So I can imagine that that's really difficult.
Yeah, they don't care. I mean, that's because they told me, oh, don't worry, go ahead. So I went, had the surgery, but somebody that was there, one of my roommates, called me and told me, hey, you need to get back here. I'm already a week gone. I'm, in recovery, because then I have to go to, after this amputation, now I have to go to therapy. So I, learn how to walk. But they were telling me they came up there and cleaned out, took all my stuff. Now, I had a total of 6 bags. Most of the stuff is what they gave me. Like they give me some clothes or some shoes like that, to help me look better to go on job interviews. See, but they said they didn't have no storage facility. But yet, no, they kept giving me this stuff. And then they were complaining about, you can only take this amount with you to the new place. Or I'm saying, well, why did you give this all? This is like Indian giving. You're giving me something now, you telling me that you have no place. So I had to wind up going out, using my own money and getting a storage facility to put most of my stuff in. Which means I didn't know that, somebody else could pay for that. I had to pay out of my pocket, which was deplenishing my money to move. Even though I had a voucher, most of these landlords do not give you what the voucher say. They want something extra. Oh, well, you're gonna have to pay the extra $200, even though they know that they're supposed to take the vouchers.
And you mentioned actually storage, which I think is also something that's really key because some people have a lot of medications to take every day. And, obviously vital documents are really important, but like medications, where did you store them? How often did they get lost or stolen?
Yeah, but I'm saying when I first went to the shelter, now I had insulin. I was taking 3 insulins, that need to be refrigerated. Now the pills that I took, they wanted to confiscate them, and I was telling them, why would I have to take them at certain hours of the day. See, you had to go look for people to get them out the safe. And if that person is nowhere around, you're running around and around looking for this person, and they get in an attitude because you stopping them from doing nothing. See, they're supposed to be helping you. But if they're in there talking in break room with one of their friends, and you like, well, I need to do my medication, which you have to keep on a constant day. Like every day, 6 o'clock, you got to take it. If you go off, that mess up the framework in your body. See, your body might be thinking, well, it's 6 o'clock in the morning or what? Like it's hard to go to sleep from like daylight saving time. And it just, you know, why, but I couldn't understand why were they taking my medication? This wasn't crack. This wasn't dope or anything like that I'm selling a reefer. This was something I kept in my locker. So when I get up, okay, my time will go up, I could take it right then and there. Now I got to go look for my medicine. See, they might be on their break. See, and they were not really showing any initiative to my welfare. Because all they did was come in there to punch the clock, you know, 9 to 5.
And Neville, did you have similar experiences with medications, with storage? I know that generally people get assigned lockers. Are those safe? Are those secure or not at all?
Well, basically on one occasion, I was at a shelter, Eddie Harris, that's on Chauncey Street. And they had all our medication in the refrigerator in the back. So that means basically like if this gentleman or this gentleman had to take their medication, theirs would be on the shelf, mine would be on the shelf. But who's to say like if we run out, we don't like, well, I'll take one of his. See, there was no constant, you know, security there. It's not like they had a refrigerator with security code or whatever, and they know who goes in or out. See, that you could monitor. There was always a fear like, oh, where's my, like if it's delivered, where's my medicine? I'm out. I only got one. Oh, it'll be here tomorrow. No, that's not good enough. Or if they're not there to pick up your medicine, they'll send it back. Now you get to reorder it, but you have to go to the doctor to have them to refill your prescription. Okay, and that's endangering you.
Neville, what was your experience? And then Barry, I'm also curious what your experience is with managing medications in supportive housing and how that looks like.
In supportive housing, when I first got here, they take your medication and you have to come downstairs at a certain time and go on a medication line. After a while, they had a new program where you have self-meds. You have to take a test. You go to the classes, take a test, and if you pass the test, then they give you a week's supply of your medication, and then they actually count it. You know, see if you're compliant, take the medication. No one knew that I was a paramedic, so I didn't take the class, and I just took the test, and when I got 100, they didn't believe it. They thought something was wrong, and then they retested me, and I got 100 again. And so far now I'm on self-medication. The problem that I have sometimes I don't always get my medication. Or the medication will come here, and they don't give it to me until like a week later. There's been several occasions that I complained about where my insulin came and it's supposed to be refrigerated, and it wasn't refrigerated, and I got it like weeks later, you know. That problem seems to be resolved now, but it was a problem, a major problem. The shelter was the same medication line, you know. What David mentioned, I did witness them where people will run out of medication, and if someone else had the same medication, they would give them this, you know, which I didn't think that was right. In the shelter system, they rob you of your dignity, and then you're constantly under pressure pressure about safety, pressure about what David mentioned about going to the hospital and not coming back and losing your bed, starting all over again. You know, it's stressful. You know, you have to wait on that bench to be assigned a bed or overnight bed, stuff like that. You know, and then when you finally get a new bed, you got to meet new people, and you know it's uncomfortable inside there. You don't know what type of people that's going to be in your dorm, you know, and what type of activities going to be going on in that dorm, you know, selling this, selling that, you know, illegal stuff, you know. So you're constantly under pressure, and
the joy bag.
and the pressure,
Okay.
and the pressure, I feel affects your health, you know. It affects your mental thinking, you know. You feel hopeless, you know. And when you feel hopeless, especially with my condition, you know, with mental health, I tend to give up, you know, and then I don't want no help, you know. And with my medication, sometimes I wonder why I'm still taking it, because I don't feel any different, and I don't feel like I need it. And there's been times that I had stopped take my medication for weeks. I'm talking about the mental health part, and thought I was okay, then end up back in the hospital, starting all over again, you know. And then I was on the metformin for years, and I just started getting sick behind it. I never liked sticking myself taking insulin. Never liked that, even though it didn't hurt. I didn't like it. But I was getting so sick behind it, vomiting, and to where I asked the doctor, please put me back on insulin. You know, I can't do the metformin. And that's what I'm doing now. I'm taking insulin, and it's 100% better. I still don't like sticking myself, but still, you know, I'm not vomiting, I'm not nauseous all day long, stuff like that.
Yeah, my supported housing consisted of getting support from the Human Resource Administration and being on public assistance. They paid my rent direct. And while I had my apartment, it was always very important that I had a working refrigerator to store my medication in. And if I didn't, there was a problem. You know, I called 411, they send inspectors out there, and before I know it, I have a working refrigerator, the problem will be corrected. So having housing for me was real important to me dealing with the diabetes.
Thank you. So it's 1:25. We're going to switch over to answering audience questions. So let me just pop into our Q&A session here. So anybody can submit questions through the Q&A button at the bottom of your screen. And you can also upvote certain questions. So if you notice there's a thumbs up sign on the left bottom of each question, the questions that get more upvotes will come up kind of to the top, and we'll go through them in that order. So if there are questions that resonate with you, feel free to upvote them. So I'm going to start with a question from Johnny Johnson. Why aren't gym programs offered in shelter systems, as it's much needed along with food when it comes to shelter? Maybe we can start by having each of you talk about what your experience was with exercise or getting physical activity while you were in shelter experiencing homelessness.
Well, for me, when I when I was homeless, my exercise was running around to get my drugs, and I was down there 24/7. However, when I got housing, and like I said, I joined adult day healthcare. They had a gym in there, and I definitely worked out and exercised with the fellas. That was one of the things that helped me to build my self-esteem. It helped me to get more healthier. And I noticed that the harm reduction program was working for me. You know, because I never thought that would help me get off drugs. But as I start dealing with my physical and my little chronic illnesses, I built up my self-esteem enough to deal with my drug problem. So.
I didn't realize. Oh, it's okay. Yeah, I didn't realize
Yep.
at the time that how important exercise was with my diabetes. However, we did have a gym there, exercise room, in the basement of Ward's Island, but the majority of people that went there were really the tough guys, the thugs, you know, and it was a competitive type of thing. I went once or twice, and I didn't really stick to it too much. Not until I got out of the shelter system and got sick again. Ended up in the hospital, and the doctor stressed that exercise is part of, you know, getting yourself better, you know, keeping yourself maintaining, you know, your sugar. And so I joined Planet Fitness, which is directly across the street from where I live at. That lasted for about 2 months, and then, you know, I stopped going, primarily because of the pandemic. Just with last Wednesday, yes, I went back to Planet Fitness and renewed my membership. So I'm taking it serious again, and I ordered from Amazon a bench so I could use some weights, you know. And I cannot do too much walking because of my knees and my back, but I do walk when I have, yeah, I try to walk.
Yeah,
Snell.
I got neuropathy too in my feet, and I have a bad knee. However, I've been cycling. I have a bike. I've been cycling for the past 6, 7 years, and that's really my mode of transportation. If I'm not taking public transportation, and I put my knapsack on, and if I have to go grocery shopping or whatever, I just throw it in my knapsack. Like I say, I'm part of a community garden, and that itself is like therapy for me to get in there and, you know, work in the garden and move around. One time I was walking with a cane everywhere, but when I joined that garden, I would ride my bike there and get off the bike, and, you know, got me to moving around, and my leg is strengthening a whole lot. So exercise is very important with me, especially being diabetic and being also on dialysis. Like, you got to keep it moving. You got to build your strength. You know what I mean? It's dialysis. It's real strenuous, but it's like something you got to build and fight against. You know, you got to deal with the pain. You got to work throughout the pain. You know, you have cramps. Like I said, I got a weak knee. I still get on the bike and ride. You know, exercise is very important.
Thank you. I wanted, oh yeah.
Just to mention, one of the difficulties that I find having diabetes, and in my neighborhood, they sell things that we readily buy, like 50-cent sodas, Little Debbie's, which I don't find in other neighborhoods where I work at. you know. But in my neighborhood, you'll find these 50-cent sodas and these little Debbies. And when you're homeless, that's what you live off of. And if you have diabetes, that's like putting a bullet to your head, you know. And it's like the system has it fixed for us, you know. The fix is in, you know. This is what we have for you, you know. Killing yourself slowly. So certain neighborhoods, to me, is designed for you not to win. You know, you have to be aware of at all times of what you're putting in, and everything that's cheap, it's not good for you. It's not all good for you. You know.
Well, that resonates with me a lot. You know, like what we see in terms of healthcare disparities. That's a direct result of how the system is built. The system is built to get the results that we're seeing now, right? Like you said, like the fix is in. It's like that's how it is. In speaking of the system, I actually wanted to jump to Corinne Hibbert's question about your like a healthcare team and your relationship with them. So you're asking, is your healthcare medical team aware of your homelessness state, and how was that incorporated into your plan of care? As a primary care doctor, I'm also curious about that. Is housing or homelessness something you're able to talk about with your doctors? How comfortable are you with that? Were they aware of that? I'll let any of you go for that question.
Well, I must. I was homeless on the street, but there was time when I had to go into detox. And I must say, when I went in there and I got to a caseworker, they seemed interested in trying to get me into a shelter or trying to get me into a drug program, which I wasn't ready for at the time. But when you run into the caseworkers that I met, they was always trying to help you to deal with your situation, you know, but I wasn't interested, you know.
Well, basically, excuse me, but my doctor used to, the ones, my home cares physicians, they used to get irate because sometimes I couldn't get my medication because no one informed me of the facilities, Medicaid, or I couldn't pay for them. So they used to tell me basically that they were supposed to assign someone to me, like a caseworker, housing specialist. See, I didn't receive all these people till after maybe my ninth week in the shelter. Someone would come up and say, well, talk to your housing specialist. I'm like, who's that? And they tell me, oh, you were supposed to get one when you came in. I said, no, they just had me sign a book of papers and assured me that I would get a copy with my signature on them. But then when the infraction was being planted on me, they were saying, well, you signed for that. See, I didn't sign for nobody to go in my locker and take everything out while I was out in the street trying to do something. They did that sneaky. They wait for me to leave to go in. Now, if you would have came up to me and say, open your locker. But no, they wanted to do some cloak and dagger. And they was telling me, oh, well, you're not supposed to have this. That's contraband. I said, well, how could it be contraband when I came in here, you got a metal detector, an x-ray machine, and you took everything out my bag, and then you told me everything's good. But only because I had went to the New York Times to expose these people, to tell them what was the conditions on that was going in this shelter, because they say, well, you're not supposed to talk to the media. And the media couldn't just come in there. So they had, Vocal New York asked me to be their eyes. So, I mean, I was trying to get people to go with me to more voices, but since no one wanted to do that because they were scared to lose their bed, I told them this is not my bed. I said, my bed got my keys to where I can go open up the door. I'm just here being detained. See, I'm only here to get help and they're not helping me. So after my story came out in the New York Times, which I figured they couldn't do nothing to me because the New York Times all over the world. So the whole world knows what this facility was doing to the people that was in that shelter. They didn't like me anymore. They wouldn't say good morning, whatever. They were like, oh, don't say nothing because they say I was taking pictures. Yeah, but I wouldn't have to take pictures if you were doing your job. If all the sanitizers, hand sanitizers, we in COVID, if they would fill up, no, they wasn't that. And if I was able to go see somebody, they're supposed to be there at 9 o'clock, but they're coming in at 11 o'clock because see, they didn't have electronic signing, they had paper. So somebody could say, oh, I'm late. Could you sign me in? But how you getting paid for 9 o'clock and you showing up at 11, and then after 11, you're going to a meeting, but meanwhile, my stuff is not getting done. You know, I need to go see this person. Oh, well, we getting ready to have a meeting. Or I have to go outside and get a smoke. I'm stressed out. I didn't tell you to go to the club last night. Or I need my coffee. See? Or then they used to tell me, they're working in the shelter that I'm at. See, but at 5 o'clock, they go home. But if I see you in the hallway, I'm like, I need to ask you about my voucher. Oh, make an appointment for next week. Well, I got to ask you next week. You're standing in my face. You don't even know what I want to ask you. See, they always try to blow me off. See, and they said, well, what do you want to ask? I said, is this, the voucher's getting ready to expire. What do I do? And then your answer, you don't work for DHS or HRA or, you know, DSS. They telling me, oh, to kick in. I said, how do you know that? Do you work down there? And they're telling me, no. I said, then how do you know? Because see, my conclusion is like this. If you give me a 3-month voucher and I haven't claimed, you know, an apartment by then, he must don't need it. See, now I got to go all the way back to square one again. But when I ask you, you're telling me, oh, I ain't got nothing to do with that. Then why are you asking me these questions like you're going to help me? You're in my business, but you have nothing to do with that. You mop the floors, but you acting like you a caseworker. Hibachi.
That sounds really frustrating. And also thank you for your work in making, you know, that situation visible to people through the reporting. I think that's really important. I wanted to kind of ask about, and I think several of these questions touch on this, which is, were there, you know, I think you talked about the housing navigation portion of it with the caseworkers and you know, at the shelter. I was wondering, were there any health related programs? Were there resources for health in the shelter system as you experienced it?
Emergency room. That's what they tell you, go to the emergency room. And it had no doctor there or somebody, you know, to come and do a checkup like that. If you sick, go to the emergency room. But if you go to the emergency room and they keep you, you lose in your bed. So nobody really wanted to go to the emergency. I went because there were several people that died in the shelter with COVID or just pneumonia or just not being able to get their right medication. See, and these people didn't care. They, oh man, you know, they call the ambulance, the meat wagon, and they just clean that bed out, throw the people's stuff away, and they bring another person in off the street. But then most of the time they do that intake late at night. Now, who does that? 10 o'clock at night, you giving me a bed, but then nobody knows who this person is coming in. And half the time when you wake up, there's somebody, you got COVID going on, people coughing, you were like, who is this person? Did you check them out? You know, did you screen them? No, they didn't do that. They just gave them a bed. And most time people just say, well, I got a bed, you know, I'm off the street. See, but you sick. Some sick people are not gonna really tell you they sick half the times. See, they got to be dragged or you know, on their deathbed before they say, hey, I need some help. Just the simple fact that that rule was implanted in most of these people. while you looking for help, and some people are comfortable being there. See, that's not home to me. So you go there, 90 days, if that's what they're giving you, and within 90 days, you're supposed to be doing something from Monday to Friday. These people weren't doing no help. See, and once Friday get there, the day come alive, Saturday and Sunday, now you got to start all over on Monday to get anything working. I don't know. There's a lot of changes need to be done for that. I just say, like, if you're going to get people off the street, just get them affordable housing right off the bat. A shelter is no place to be having people not quarantined, but you're supposed to have 6 feet. We didn't have 6 feet. We had 6 inches. See, the more beds, the more money they get, or more what we say, more funding. See, we didn't get, basically in the shelter I was at, we did not get any new clean linen till when they get ready to get their raise, what they call that a Callahan Day. See, now they're running up and down this place, painting and giving you new sheets, toothpaste, like the care package when you come in there. But shouldn't we get new sheets every 2 weeks or something like that? Or soap to wash? We got the water, but they wasn't giving you that. They was giving you that so they could make themselves look good. And then the troublemakers, which I was one of, see, they'll send me out on a ghost front. They'll send me someplace to go look at an apartment, so I couldn't tell, like the Geneva Commission come there to tell them what was going on. Because see, I wasn't there. By the time I get back, everything's back to normal.
So I know,
go ahead, good.
and so you mentioned Callahan. So I know Callahan is the name that's associated with the case in the 1980s that established the right to shelter in New York City. Is that what you're referring to, or are you referring to something else?
Well, that's what they were telling me in the shelter, that these people getting a raise or they get more money. See, because you're making it look like there's no rats or there's no roaches or there's no, there's no extermination going on, and you're getting the good food now. So you're not getting that pizza that you give the kids in school, the one you got to throw in the microwave. You getting Tony's pizza, slices of pizzas like that.
Gotcha.
Yeah, you're not getting the garbage.
Yeah.
I'm telling you, they counterfeit.
Neville, did you have something that you wanted to say?
Yes, in my opinion, the shelter system is designed for failure. And it is true what David said. They make a big thing once a year. They when they have their Callahan, and that's when everything comes new. All the painting and stuff is done. But in general, there's no emphasis on health, and it's reflected in the food that they feed us. And even the portions. And being that at some point they hired me to cook there, I was seeing how they was preparing the food, and a lot of the other cooks didn't like me because I would clean and the backs of the chicken, I would clean the back, I took all the membrane. They just chopped it and threw it inside the pot, and they would forget and say to me, "Oh, they eat anything," but I'm part of they, I gotta eat it. I gotta eat it too, So a lot of times when I cooked, everybody knew it was my day to cook because the food smelled different, The whole Chef Neville's there, we gonna eat good today, And I emphasize on cleaning, and parts of the meat that we shouldn't eat was discarded, We got 200 pounds of chicken donated one time. The chicken came with the head, neck, and feet. And I was told, and the chicken was white at that. Not the yellow, was like it was white. I was told to chop the chicken up and to put in the big kettles. We have these big kettles that you so big you get into it. And make soup. And I that's what I did. And the feet to the side, the neck and head put to the side, and the rest I put in the kettle. later on, when the food is being served, I like to go outside and see the reaction of the people, the clients, and get their feedback. So I know what to change, or how I can make it better. And I started hearing people mumbling, and then one guy screamed and he threw his plate. And then everybody starts throwing their trays. And I started seeing that most of the Haitian people there took offense to the food. I couldn't understand, because I take time, and care and love. Come to find out that the heads were put in there with the eyes, they dumped that back into the pot that I was throwing away. And some of them got the heads with the eyes and all that. And to some of the Haitians, it was some type of religious thing. And they was just trying to, to use everything, After I discarded it, they put it in the pot anyway. So my point is this: there's no regard to people's dignity in the shelter. The shelter is designed for failure. The people that don't fail are the people that push every day. Stay with your case manager, push, ask questions every day. Those are the people that lead the shelter. But when you see people inside there that don't push, and then you see people that get comfortable to the point that they have robes on, like they're in a hotel, if you're that comfortable, then you're not gonna leave, There's no encouragement on doing better. And the focus should be on health and mental health also, because if you don't have no desire, then you're not going to take care of yourself. And if that's not reinforced in the beginning when you first get into the shelter, and then constantly reminding you all through your stay, you're going to get lost in the source. You're going to either stay there for a long time, or you're going to be part of the problem, selling drugs inside there, or getting sicker. You're going to aggravate whatever problem that you have, high blood pressure, diabetes, and that constant pressure every day. Am I going to lose my bet? Am I going to be disrespected? It's just pressure. It's like I said, it's designed for you to fail. There needs to be changes.
Mhm. It needs to change. Yeah.
Yes.
So the questions at the top here from Carolyn and Natalie about kind of things being done to improve health of residents in shelter, or whether or not there's any programs or education that's offered regarding health in shelter. It sounds like we've kind of, from what you've answered, it sounds like there hasn't been too much there, and that, from David, what you said, it sounds like they do encourage people to go to the emergency room, kind of as a measure. Do any of you know if that situation has changed? I know there's a question about whether or not there's been improvements in that regard to the shelter system, or if any of that has been addressed program-wise.
I have a friend that's in the shelter still, and he told me that someone else took over. When I was there in Ward Island, it was run by Volunteers of America. He said that they're no longer there. There's a different company there. In addition to that, he said that it's even gotten worse, fights all the time, There's no emphasis on health at all. He's also diabetic, and he takes his metformin. He doesn't have to take things to take metformin. He says nothing changed, and I don't think that it will change, and that's why when you leave the shelter, if they don't educate you on when you get your own place, that's the whole premise. When you go into shelter, you're supposed to transition into permanent housing. If they don't teach you while you're in the shelter, what you need to do when you get out of the shelter, like take care of your health, go to the doctor, take your medication, They don't teach you that there. Then when you come out, you go into the same thing. It's a vicious cycle. You're back. That's why people back in the shelter, because you're not educated, And then there's no examples. There's nobody that's successful that made it through the shelter, coming back to the shelter to show them this is how I was, how it was back then. And look, I became successful. I'm working. I'm doing this. They don't emphasize on that. I'm bringing people back and showing it can be done.
It sounds like the education aspect on the healthcare system side is also not there to help people maintain that, to tell them kind of like how, in the long run, diabetes can be helped. And maybe there's also there's a lack of awareness among healthcare professionals as to what it's like in the shelter system, or living in an abandoned house, and that's also why we're all here on this call. And so it's 1:53. We have until 2. I wanted to ask one final question and see if each of you could respond to this, which is, what would you want your healthcare team to know in order to help improve care for people experiencing homelessness? What do you wish was something that your healthcare team could understand? And I'll let each of you give your answer. Barry, maybe we can start with you.
One thing I've been trying to work on with people is the 2010E, the application for getting priority housing for people that have some sort of disability, be it mental, diabetes. There should be some sort of priority for sick people, for people that's sick and living in the shelter system. And if they can get that application more easier and push it through the process, I think that would be real good. I had a lot of people I know got out of prison, and if they had some sort of disability, that was the application we used. And long as they was in the program, it seemed to help them get housing quick. Yeah.
I think that I'm sorry.
Mm-hmm. Good.
I think that there should be more fairness going around. The system is not fair. You have people in the system waiting for Section 8 for years. People in the system waiting for healthcare and this and that. Then we have a crisis where you have migrants coming across illegally, and now they get the Section 8 as they come here. But people that's been here all this time, waiting on a waiting list, doing lottery, don't get housing. And we're here doing the right thing. I don't understand that. It's a mental strain when you think about it. You're waiting all these years, then somebody just jumps the line. They jump the line, and what about me? I just don't understand it. Then you wonder why people give up. I just don't understand it. I don't understand it. You have to fight for yourself. It's like a dog-eat-dog world. Everybody's grabbing at the top. Grabbing to get to the top, and you have to be like that, or else you won't get nothing. You will not get anything. Closed mouth doesn't get fed.
Oh, me? Oh, well, basically, I would love to see a better healthcare as far as in the shelter, like maybe they could come visit to like doctors or whatever, because see, basically they could have like patients there in the shelter. Or have a truck come by, so that way they won't be, out there element as far as losing that. They could come there and you won't lose your bed. You could just tell them what's wrong with you, and then they could prescribe whatever medication or whatever health plan or whatever clinic you can go to, because see, they're not really doing that now. See, because they're figuring that that's not in the budget. And as far as like people coming in and taking, I mean, I've been there for 13 years, and I don't think it's right, because see, we had to wait till you're 16 to get your working papers. They're trying to put people to work now. But I mean, like, how come that don't happen to me? I help vote. I help a lot of things, and I don't think that they should try to clean up the front of the yard when the backyard is still dirty. So you still got people sleeping on the street. What about them people? Why aren't they in these new hotels that y'all been opening up for these people, or these schools that you've been opening up for these people coming up here? I'm not saying I'm against anybody trying to make a better life, but I mean, shouldn't they go, like he said, in the back of the line, take care of who's been here first, instead of dragging them off the street, putting them in hospitals or throwing them in jail? See, people will do that because it's called survival. People do things to survive. They're not mental. Some people are mental, and some people just are fed up. Some people figure they go to jail, they get better care than they're getting out in the street. And some people like to be in the street. See, me myself, I'm in the SRO, which to me is a mini shelter. I'm in there sharing this building with 9 other guys, but I'm sharing a bathroom. I'm still sharing a kitchen. See, I only took it because I didn't want to be in no shelter where they're telling me I got to go to bed at 9 o'clock. And then they're going to wake me up at 10 o'clock telling me it's a bed check. How's there a bed check and I came in here? I got to get past you in order to escape, but where am I going? See, that don't make no sense. You only can get certain privileges unless you work it. But no, that's all I said. I almost got irate. I'm sorry.
No, please. I mean, this is what we're here to hear about, and, we're at time, and I wanted to just say thank you so much, David, Barry, and Neville, for joining us. And I'm going to pass it on to Constance to give some closing remarks.
Thank you, Michael. I'd like to thank all of our amazing panelists and moderator for making this event possible. Thank you so much for joining us, and we look forward to seeing you at our next event. Have a great day.
Thank you.